Tim Keane is a Legionella control engineering consultant and owner of Legionella Risk Management, and he will be our next speaker. He is a licensed marine engineer with 35 years engineering experience in various capacities, including design, construction, commissioning, facility management, and water system consulting. Tim has been a water system consulting engineer for 23 years, with the last 12 focused on waterborne pathogen management. He has worked with healthcare, commercial, industrial, and municipal water providers in the United States and internationally, implementing waterborne pathogen programs, performing outbreak investigations, and consulting on water treatment issues. He is a member of the ASHRAE committee that developed the new ASHRAE standard on Legionella control and is the author of numerous research articles. So please welcome Tim Keane.
Thank you. Well, one thing I'd like to say is this is a great forum. These presentations before me have been phenomenal, including the one that mocked my accent on the pronunciation of water. But we'll get beyond that. Yes, I'm from Philadelphia, and we do say water incorrectly. I'm here to talk about electronic faucets and water efficiency and the impact that's had on disease. But I just wanted to say that all the discussions that came before this have been great. They've talked about, in general, what I'm talking about in particular. And that is the holistic view of looking at water savings, looking at energy efficiency, and looking at what that impact may have on waterborne pathogens. Janet kind of wrapped all that up and discussed water reuse and those systems that have an impact. So just keep your mind open and think about all the things that have been discussed this morning about water savings. If we're reducing water consumption, we're reducing water flow, we're reducing water turnover, we're reducing water velocity. If we're reducing water use in municipal water systems, we're increasing water aging problems. So all of these things have an impact. For every action, there's an equal and opposite. And the opposite reaction that Janet was talking about and that I'd like to discuss is when we reduce water consumption, when we reduce water usage, when we reduce water turnover, we increase pathogens and the potential for pathogens. We talked a little bit about Legionnaires Disease, and I'll just highlight some of the facts out there. Janet talked about 25,000 to 30,000 cases a year. And to answer the gentleman's question that was posed to Janet, about 5 years ago, there was a Legionella conference in Chicago. And one of the questions was asked was, and there was a lot of MDs present at that, was what do you do as far as Legionella identification in your hospitals? CDC has a recommendation that all hospitals, when they have cases of community-acquired pneumonia, and those people have risk factors for Legionnaires disease, that they should be tested for Legionella. The overwhelming response from that group was, that test is just not worth it, we don't do it. So there is inexpensive testing out there, but if you do that $50 to $100 urine antigen test on everyone that presents symptoms for pneumonia and has risk factors for Legionnaires disease, many hospitals think that's a very expensive cost and just don't do it. One of the misnomers out there, people think it's only in hospitals that we have an issue, and I hope that percentage that you see there, 23% healthcare acquired, 77% community acquired. So hotels, office buildings, homes, that's where the majority of cases occur. Now, when you look at the amount of hospitals as far as percent of population that's in them, you may have percent per thousand that's higher in hospitals and long-term care facilities. But do keep in mind 77% of Legionnaires disease is non-hospital related. Frequently, I talk to people in hospitals and they say, well, we don't have any high-risk areas. We don't have bone marrow transplant areas. We don't have chemo. So we really don't have to do anything as far as Legionella control. You have people walking today, and this is something that a lot of people don't realize. As we improve just about the corollary with the water issue, as we improve water reduction, water efficiency, we're increasing the potential for pathogens. Well, as we improve our medical state, we're improving our lifespan. We're improving the amount of people with cancer that are living longer. So the percent of our population with disease or risk factors for Legionnaires' disease is growing constantly. And that's because of our increase in medicine. Doesn't make sense, but it's true. Diabetes, we have more people with diabetes, we have more people on steroid treatment, we have more elderly people, we have more people with bone marrow transplant. And when you have a transplant, you're on immune therapy for the rest of your life, and you're at increased risk for Legionnaires' disease as well as some other pathogens. 4,000 estimated fatalities a year. $34,000 is the estimated cost just in medical treatment for Legionnaires' disease. CDC came out with a paper last year on this, the most expensive waterborne pathogen to treat. 219% annual increase in reported U.S. cases from 2000 to 2009, another CDC report. And about 120,000 estimated deaths since the disease was identified in 1976. And again, many of the cases are not hospital acquired. They're community acquired, hotels, apartments, office buildings, homes. There's been guidelines out for over 2 decades on water and water temperature as a method for controlling the risk of Legionella. OSHA says to maintain domestic water heaters at 140 degrees and water at the faucet at a minimum of 122 degrees Fahrenheit. ASHRAE Guideline 12-2000, over a decade old, talks about conditions that are favorable are between 77 and 108 degrees Fahrenheit. That's the temperatures where the bacteria will grow at the greatest rate. And ASME guidelines that came out in 2002 talk about the same temperature. So we know temperature is a simple, easy, and effective method for controlling Legionella and waterborne pathogens. And it's been well known for over a decade. When we talk about electronic faucets, there's been a lot of papers on the issue of electronic faucets and the problems associated with them. In 2001, there was a paper by Halibi. 2002, there was one on sensor-operated faucets. And in many of these papers, it has been medical research that has done and looked at the disease associated with the faucets. And one thing I want to caution is, of all those papers listed, to my knowledge, only the last paper, the one done by Hopkins, included a cross-functional team that included an engineering component. So there were engineers on that last paper, not just medical professionals. So when you look at research that's done by people on plumbing fixtures, look to see what the knowledge base of that research is, and if there's people with actual plumbing or engineering experience involved in that research. And the Halibi article, paper, that's one of the most well-known on electronic faucets. It was a large study, and they mentioned they did a detailed analysis of the contamination, and I highlighted in blue the low amount of water that flows through the outlet was one of the deciding factors that they felt was a problem with electronic faucets. And also the low temperature was another issue they felt was a significant problem with electronic faucets. And they talked about materials of construction as well. The sensor-operated faucet also talked about issues with other pathogens, and many of these papers, by the way, on sensor-operated faucets weren't on Legionella, but they were on Pseudomonas and other pathogens. And it talked about continuing results. We need to conclude that sensor-operated faucets must be constructed so they do not promote the growth of microorganisms. The length of pipes connecting the valve and water outlet must be short. And another paper talked about the same issue. We want to control water flows at the outlet with electronic faucets. That's one of the principles behind their use, is dramatically reduced water use. And as I mentioned earlier on in the presentation, when you reduce water use, you increase water age. You reduce the amount of disinfectant in the water. You increase the amount of bacteria in the water. That goes along with Janet's presentation as well. The remaining column of water in the faucet has a temperature of about 35 degrees Celsius. Again, this is a common theme in all these papers. and they talk about materials that harbor bacteria and promote biofilm growth. Another paper talking about electronic faucets in hematology units comes up with the same conclusion. In addition, despite hyperchlorination, the electronic faucets remain contaminated, and only the replacement of contaminated faucets by manual faucets led to control of the bacteria. So that's another issue when you have low flow. If you're trying to do disinfection with extremely low flows through the equipment, you're going to have much poorer results. Some of these studies were done on old versions of electronic faucets, so when you look at these papers, you got to also keep in mind what was the components that were researched, what were the manufacturers, what was the technology. Many of the papers don't point that out. So that's a question mark on much of the research. This one did. In response to the original Hopkins paper, a lot of people came out and made statements that said, well, we're not sure what the impact of this technology is. We need to think about it. ASHI and APIC came out with a joint statement in 2011, shortly after Hopkins' presentation and about a year before Hopkins' paper, which came out a few months ago. And they said that several studies said handle-operated faucets were a source of infections. Well, you can get Legionella growing just about anywhere. If you have a central system that's a problem, you're going to have it coming out of ice machines. You're going to have it coming out of faucets and showers. It said another study looked at the source of the bacteria and that, in fact, manual handle-operated faucets were one of the sources. Again, if you have low flow, if you have issues with the faucet design or operation. I was in a facility that has 100% manual-operated faucets, and about 10% of them didn't work. So maintenance has a huge impact on the issue as well. And then we come to the Hopkins study, and the Hopkins study finally came out just a few months ago, and it talked about the same issues that have been raised by others. It talked about flow, low flow rates, and electronic faucets' interior components. And it talked about also temperature, and the temperature of 35 degrees C was the same temperature that they had in their faucets. So issues that we know and we have known for a long time impact pathogens in components: velocity, consumption, turnover, and temperature. Temperature being one of the most key. In my outbreak investigations, I've found that velocity is even more important than temperature. I did a study of a municipal water system in a small island south of here, and the system used seawater to generate their potable water. The average temperature of the municipal water in the system was 95 degrees Fahrenheit. That's the cold supply water. And we found no Legionella at all in the system except at the fire mains, very little amount. So temperature is an important factor, but if you have good turnover and good flow, that can do a lot to mitigate the potential for the problem. And also what came up with the earlier studies, again, combined with the Hopkins study, temperature and flow, temperature and flow. So is the problem electronic faucets, or is it one of the features we're looking for in electronic faucets, and that is lower temperature and lower flow? These were pictures from the Hopkins paper. It showed their manual wrist blade faucets compared to their electronic faucets. And it discussed the components that are in the electronic faucets and the fact that there are more parts inside the electronic faucets where biofilm can grow. It shows there the pre-filter on the supply hose for both the cold and the hot water lines. It shows the reduced flow aerator, and it shows the solenoid valve for the electronic faucet. And in comparison, a manual faucet is a fairly simple device. So simplicity has something to do with it as well. When you look at investigation results, data from Legionnaires Disease and healthcare facility demonstrated conclusively that the impact of very low flow faucets on Legionella disease and outbreak. So this was an outbreak I was involved in. I collected the data, and we looked at the information. We collected a good bit of data Similar to many of these other studies, we actually collected 13 samples from electronic faucets. We collected 12 samples from mixing valves, shower mixing valves, and 14 from manual faucets, each in a patient's room. A shower, a sink faucet in the restroom that was manual, and the electronic faucet that was used at the nurse's station. And the results of that study were pretty conclusive, and this was following a significant sized outbreak in a healthcare facility. This hasn't been published yet, but we do plan to publish this information hopefully in about another year. We looked at the data we collected and we found that 61% of the electronic faucets were positive for Legionella. 13% of the shower mixing valves were positive for Legionella, and 0% of the manual faucets. So that's some pretty significant results. And we looked at what were some of the other factors that impacted this. The electronic faucets had very low flow. They were 0.5 GPM. So we know that's definitely an issue that's been raised in prior studies, is the flow through the faucet. The shower mixing valves had 2.5 GPM going through them, and the manual wrist blade faucets in the restroom had 1.5 GPM. So we had fairly good flow in those. Were there internal strainers or any other components that could get fouled? The electronic faucets do have internal strainers. The shower mixing valves did not. And in this case, the manual faucets did not have internal strainers. Was there tepid water involved? And as discussed with the other papers, the electronic faucets had tepid water, approximately 108 degrees. Lower than 108 degrees, we had about approximately 100 degrees in these electronic faucets. The shower mixing valves did not have tepid water restrictions, and the manual faucets did not have tepid water restrictions. So that's another significant factor. When you think about it, these are factors that are associated with electronic faucets, but these are not factors inherent in the design of electronic faucets. Electronic faucets can operate at higher flows and at higher temperatures. And internal check valves. There's internal check valves in these electronic faucets that we studied at this outbreak. There were internal check valves on the hospital, on the shower valves, and the manual faucets had no internal check valves. So these were the issues that we looked at as unique factors in the system that could have facilitated the bacteria growth, and that gave us significant results, 61% positive in electronic faucets versus 13 in shower mixing valves and 0 in manual faucets. When you look at the factors involved, very low flow. What causes that? Well, one of the factors is complying with LEED and other guidelines, plumbing guidelines. Talk about lavatory sinks having 0.5 GPM. So when we're talking about saving water and we're talking about all the issues we've been talking about, this is one of the realistic outcomes. We have the potential for increased bacteria growth if we have lower flow and lower temperature. Temperature at 95 degrees. We know that's one of the highest risk temperatures for Legionella colonizations. So when you design a component that's going to operate within that temperature range and at an extremely low flow, you are definitely exacerbating the problem. Potential for leakage across check valves. What some of these systems have is you'll have the hot and the cold water connected through the electronic or the single lever valve, and if the check valves fail or one of the check valves fail, you can get the hot water bleeding into the cold or vice versa, depending on whichever is the highest pressure system. And when that happens, then the cold water, if it's getting hot water bled into it, can become tepid at that point. Potential for strainer fouling, especially in new construction. Well, one of the things that hasn't been mentioned yet, we know there are issues with bacteria, we know there's issues with Legionella, and we know there's a lot of issues that we're learning more and more now. When people think of Legionella, they typically say, well, that's something in old buildings. About 25% of Legionnaires disease outbreaks are in buildings less than 1 year old. And think about it, less than 1 year old. So that has a big impact on when we're looking at design, operation, and maintenance. We're learning from this that there is something involved here. Potential for biofilm growth on surface areas, temperature, flow, and materials. Again, if we have low flow, we're going to have a better potential for biofilm growth. If we have low temperature, we're going to have a better potential for biofilm growth. Are these issues that are inherent in the product design? No, I think the biggest impact is the codes that are saying we want lower flow or the initiatives for water conservation. I've talked to some facilities that are involved in getting LEED certified. And some of the hospitals in particular said, you know, we're going to be LEED certified, we're going to get our certification, but when we look at the issues associated with water, we decided we're not going to go for those few points that's going to impact our certification. I think this is a big issue. I think it combines extremely well with the other issues mentioned this morning, that we want to use good technology and good sense. We want to reduce water consumption, but we want to also look at what can happen as we move ahead. Legionnaires' disease used to be called, when it first came out, the disease of modern plumbing systems. That Legionnaires' disease became a problem as we stored water and as we heated water. And I think in the past 10 years, we've come up with all these initiatives for saving water, and we've made that old adage, the disease of modern plumbing systems, even more relevant today than it's ever been before, because it does have to do with new component, new design, and largely new codes and regulations that are trying to reduce water consumption, reduce water temperature, reduce energy consumption. Just looking at a couple of the codes out there, individual shower and tub control in 2012 UPC is 120 degrees Fahrenheit. Now myself, we talked earlier, OSHA says 122, ASME and ASHRAE also say 122 or 124. I would love to see these guidelines personally go from 120 to 124. When you look at the scald potential at 125, it's still pretty safe water, and that would have a big impact on safety. And then when you look at the next one, public lavatories, UPC code says 120 degrees on sink temperature in public lavatories. Same as the showers, kind of makes sense. Go to IPC code. It talks about tempered water being 85 to 110 degrees Fahrenheit. We mentioned earlier, kind of like the perfect range for bacteria to grow. And it also discusses that tempered water should be used in lavatory sinks. Now the previous code said 120 degrees. This code is saying we want 110 degrees. So when you looked at all these papers earlier that I've gone through, they were all at 95 degrees, all at that range of the 110 or less. If we could change that code and increase the temperature to 120, I think that would have a significant impact. And when you look at the code wording, I've done a lot of commissions of buildings, and I'll go through the building, and the whole building is at 110 degrees Fahrenheit. And I talk to the plumbers, and they say, well, that's what the code requires, public lavatories. It talks about lavatories used by employees, and it talks about public lavatories. So by inference, a patient's restroom sink would be a public lavatory. A sink inside a hallway in a hotel or in a hotel room sink would be a public lavatory. So that's another issue, is confusion on what the intent of the code is. And bathtub and whirlpool is at 120 as well. And when you look at the flow, when you look at the temperature, I got to scratch my head, and maybe somebody in here can straighten me out. But when I've got a lavatory sink at 0.5 GPM and 110, and I can at best stick my hand in there, and it takes about 2 seconds to come out, versus I'm in a shower, and maybe when we're talking about codes, we're talking about elderly and infants that can't get out of the tubs quickly. So we're completely immersed in a tub, we're in a shower, we got water coming out at 2.5 GPM or 3 GPM, pretty high flow. We can have that at 120. But when we stick our hand in a sink that we can pull out in a second, where we've got a 0.5 GPM flow restriction, We only have that at 110. That just doesn't make sense to me. Maybe somebody can explain that when I'm done. When we look at tap scald prevention, that's a big issue. That's a big issue in this audience here. That all was started by consumer safety product research, and they talked about household scald prevention and the impact of temperature in households. And they talked about tap water scald burns in children and the impact in households of scalding burns. And consumer safety products says to avoid it, we want 120 degrees Fahrenheit may be necessary for residential water heaters. And this is grown from household and residential to codes that now require these temperatures in all office buildings and hospitals. And again, if we could have 125, say, in a hospital where we know there's not going to be unattended infants in tubs or unattended elderly, that might have a big impact on reducing the risk for waterborne pathogens as we try to cost effectively save water and save energy. And again, we talked about the temperatures before. OSHA, ASHRAE, they all talk about the same temperatures. One of the things I see quite frequently, this was a study from CDC where they talked about estimates for scalding and the potential of scalding issues with the elderly. Elderly are one of the biggest risk factors for scalding. They looked at the amount of cases, 8,600 cases annually resulting in hospitalization for the elderly, and of that, 220 were due to bathroom-related scalds, hot water, as opposed to kitchen-related, electrical-related. And this is something I wanted to finish up with, is increasing awareness. I think Janet had mentioned that as we go forward and we try and reduce water consumption and we try and do all these things that we know has the potential for a reaction of increased pathogens, I think people should keep in mind the pathogens. If you buy a hot water heater, you will find on every manufactured hot water heater an important safety notice about scalding at 120 degrees. I've tried to find safety notices about Legionella below 122 degrees on some of these plumbing fixtures, and I haven't done it. And I think this is a great group that one of the base steps we could take to increase awareness is to just shy away from not talking about Legionella and get it out in the open. This group, the plumbing industry, brought the scald issue out in the open and has made it extremely well known. If we could bring the Legionella issue out in the open, I think we could get some of the conclusions that we need to take and some of the resolutions we need to make to resolve this issue. Thank you very much. Any questions?
We have again, Tim got a little bit of a late start, so we do have a time, I think, for a question or two. Or three.
Okay, whatever.
Yeah, my name's Bob Seams, a member of the Board of Directors. What's your thoughts on Iwash stations, where that water sits for weeks and months, and it might be out in a factory where the temperature might be 80 degrees?
Bob, that's a great question. I just toured Hopkins' new hospital last week, the one that was in this paper, and I wanted to put the picture of the Iwash station they had, and I forgot to, so mea culpa. But one of the manufacturers came up with a new Iwash station, and that's a great story. Very quickly. One of the biggest problems with Legionella is goofy design. It's not just components and codes, but some of these people that just aren't aware. I was in one hospital where I was doing a design review, and the designer said, you know, we have to put Iwash stations on every floor. I think I can save some money on these backflow preventers. I'm going to put a closed loop in for the Iwash stations. I can't tell you how much time it took me to get that nixed from the design, and I hope you're not watching. They said, if you do that, you're going to have about a 1,500-gallon system. And you're going to have to purge that 1,500-gallon system at least once a week, and that won't be enough. It's one of the dumbest things I ever heard of, and that happens every day. So Iwash stations are a good example. They're hardly ever used. What Hopkins had was one of the Iwash manufacturers came out with really neat thing, and I love neat, simple solutions. It was a simple sink faucet. You turned the head around, and it turned from a faucet into an Iwash station. So they don't have any Iwash stations. They have this attachment on their faucet, and it's got a temperature control in it as well to give you tepid water. So there are solutions to these problems. This manufacturer came up with a phenomenal one, because we talk about that in ASHRAE committee a lot, is what do we do with Iwash stations at the end of the system that are not only a dead leg, but a very long dead leg? Perfect. Great question. Thank you.
Hi, I'm Mariana Nicolai. I'm with Sloan Valve, and I have two questions regarding this study. One of them is regarding the study of electronic faucets with higher flow, like over 2 gallons per minute. If it was like comparable study between less than 1 gallon and with 2 gallons like per minute, so that one. And the second question is about the test, like with higher temperature water at 120 degrees Fahrenheit or 49 degrees C versus 110 that was published in the study.
Very good question. And you're talking specifically about electronic faucets?
Correct.
Yes. That hasn't been done yet. But the Hopkins study that was focused on apples to oranges, and initially that information did not come out last year. It did come out this year. That it was an apples to oranges study. It was electronic faucets with 0.5 GPM flow restrictors compared to manual faucets with 2.2 GPM, and the manual faucets won. So what they are doing, and I know others are doing as well, is looking at electronic faucets with 1 and 1.5 GPM flow restrictors. Thank you, that's a great question, because even at that flow, there is huge benefit to electronic faucets. And I think, and one of my recommendations has always been 1 GPM and above, and you can still get water safety. And I even wonder if you're going to get water reduction better at the higher flow, because a lot of feedback I get from people is at those extremely low flows, people become annoyed, and you don't get the result that you want. So, and the other thing you look at is measure the temperature. And when you're using those extremely low flows and you've got a drop leg from your header that's a 1/2 inch, it's the same size drop leg for a 0.5 GPM aerator as it is for a 2.2 GPM. It might take you 2, 3, or 4 minutes to get hot water because it's coming so slow out of that pipe. So the water age in that drop leg is extremely long as well. And maybe, we don't know, it may be more of a problem. But I do know for sure that your question is being looked into, and there are people now doing these studies with higher flow rates and hopefully higher temperatures. Thank you.
Hi, Tim. Dave Viola. Question about remediation disinfection strategies. Are you familiar with any efforts underway in healthcare facilities and elsewhere to address periodically, disinfecting, remediating the system, and maybe some technological advancements, maybe within fixture fittings, faucets, to allow high volume flushing of high temperature water or chemicals to, deal with this issue?
Another great question, and that's like a 30-minute answer, but I'll try and give it to you shortly. Hospitals have issues, and one of the things I talk to about hospitals, and I know this is going to be on YouTube, so I'm trying to say it gingerly. When I do presentations, I look at the risks of waterborne pathogens in buildings. And one of the things I say is, when you look at the building and the building type with the highest risk for waterborne pathogens, not Legionnaires disease, is hospitals. They're required by code to have more sinks than any other building. It used to be, if you go into a hospital today that's more than 10 years old, talk about the disease of modern plumbing systems in the last 10 years. If you go into a hospital today that's more than 10 years old, you will find 2 people in a bedroom, and I've been saying this for 10 years, so you'll find 2 people in a bedroom and 1 sink in the restroom. If you go into one that's built less than 10 years ago, you'll find one person in the bedroom and 2 sinks. We've increased the amount of sinks per patient by a factor of 4. And the plumbing code hasn't changed. So one thing that came out in the Hopkins paper in 2002 that I co-authored was the velocity of the water in that building during peak demand was 1 foot per second. 1 foot per second during peak demand. The pipe sizes were grossly oversized, and we've known that for over a decade. That the plumbing code needs to be revised also when it comes to calculating pipe sizes. So I got off track there, but when you talk about hospitals, one of the big things we want to do is get the code changed so we can have smaller pipes and higher velocities. It's going to decrease construction costs dramatically, and it's going to decrease bacteria dramatically. When you talk about some of the other things, we found that temperature is really not a good remediator. So if you're looking at short-term disinfection using high temperature, 150 or 160, it's the most expensive method to use. It's the most time-consuming method to use. And it's the one that gives the quickest and best potential for rebound. So we're learning things over time. Temperature was one of the first remediation strategies. People used to say it's cheap. Yeah, it only takes about $12,000 in overtime hours to go and flush each one of these sinks individually. Very expensive. So we are learning. There is no simple solution. One thing I can say I see time and time again is design issues. I'm not going to tell you some of the other really dumb things I've seen on design, but keeping it simple, keeping it as simple as possible with the fewest amount of pipes, with the smallest size pipes, get rid of these ideas that I'm going to reduce my backflow preventer costs by putting in a central one safety Iwash system. That's not the dumbest thing I've seen, and I can tell you we had a discussion last week at ASHRAE, or 2 weeks ago at ASHRAE 188. Somebody said, well, let's put a note in there that this issue we're talking about only happened because of some unique design error that caused this unique outbreak. And my response was, I see unique design errors almost every time I go into an outbreak. So,
Andy, you had maybe make that the last question?
Tim, congratulations for bringing up and exposing the law of unintended consequences based on actions on sound science that we've known, but science changes. Now, a lot of what was discussed over the past couple of discussions was based on perception. I was at Hopkins last week for other reasons, and I knew about the study, and I asked the question of some of the healthcare workers about did they know why they're using manual faucets now versus electronic faucets, and I think it's about 100 of those. And some of the people, what I got from them was, are we going to wash our hands as much? And one of the leading causes of death in the United States are nosocomial infections. And the number one preventative measure for nosocomial infections is washing your hands. And if we don't educate people through ASHI and APIC and people like that, to let them know that there are reasons that you should be washing your hands even more, but they're getting this story based on poor perceptions, based on some of these studies, that maybe we don't want to put our hands under there. We've got a real problem in this country, or the world.
I agree with that, and that touches on one of my other kind of issues. 25,000 cases of Legionnaires disease, it pales in comparison to hospital-acquired infections passed on by hand. So that is a huge issue. Hospitals have known about it for a long time, and hopefully they will. But one of the things I see that gives me some concern is I've been involved in hospital infections and inspections, and one of the number one things that hospitals are hammered on when they get to do their CMS inspections is the inspector will come through and he'll say, I'm going to check all of your fire stops. They want to look through the walls for penetrations and make sure they're all covered, all the plumbing penetrations are all covered so we don't have any potential for fire. Anybody want to guess how many cases of hospital-acquired fire there is a year? 5. 5 cases average we have of fire incidences where 5 patients a year get impacted by fires. compared to all these thousands of cases of Legionnaires disease. So awareness is really a key issue, and it's something that we do need to improve. So thank you very much.